Hello, my name is Helen Ramsey and I am a Public Governor for Oxfordshire for the South Central Ambulance Service. In my day job, I am also an engineering manager at a medical devices company, and I understand how difficult it is to meet healthcare needs during the pandemic. But the ambulance service has not only met all these significant challenges of COVID, but has also led many areas of the pandemic response nationally. It is a great honour for me to be able to introduce the inspirational John Black, who gives an excellent overview of the ambulance service's response to COVID, covering the initiatives, the best practice, the clinical research and development, as well as his own personal story of how COVID affected his family. Here is John's excellent update. Thank you very much for listening.
Good evening. My name is John Black and I'm the Medical Director of the South Central Ambulance Service. I'm an emergency physician by background and also work at Oxford University Hospitals. Our incident command procedures are in place, so our bronze, our operational level of commands within the ambulance service is running on a daily basis. We regularly report up to what's known as the NAC, which is the National Ambulance Coordination Centre, which is being hosted in the West Midlands. We report a lot of operational level data, and we've got much more robust processes in place for mutual aid should those situations arise. I think it's fair to say that this pandemic has represented, for me personally, probably the greatest challenge of my 35 years in clinical practice in the NHS. By late January, early February, Professor Keith Willett, who has been the strategic incident commander for the NHS for exiting the European Union, was asked by the government to take on the strategic major incident response for NHS England when dealing with a pandemic. And in early to mid-February, Keith started to broadcast for all senior leaders in the NHS in England, including medical directors, chief executives, chief nurses, and he also encouraged senior clinical leaders from emergency medicine and from emergency planning, resilience and response teams who would be coordinating the NHS's response at national, regional and at local level. The first part of the UK that really developed the most significant experience managing COVID from an ambulance perspective was the London Ambulance Service. You'll be aware that SCAS and the London Ambulance Service have formed an alliance which have been in place for many years. And in fact, I have a close working relationship with Dr. Fenella Wrigley, who is the medical director of the London Ambulance Service. And I was able to obtain, with Fenella's support, the initial guidance that they'd produced for their frontline staff at a time of very significant challenge. And the problem that we initially faced in London, and indeed in the southeast of England when the pandemic progressed, was that we were seeing very sick patients with COVID present to us with this very disconcerting clinical syndrome of patients were clearly unwell. They'd had flu-like symptoms for about a week, and then they had deteriorated. Many of these patients started to become confused, and family members noted that many of these patients appeared to be very cyanosed, they appeared to be very blue, and yet these patients were not complaining of feeling breathless. They seemed to have very little in the way of distress, despite having profoundly reduced levels of oxygen, levels of oxygen in their blood. And so at that early phase, the patients that we were seeing predominantly were very sick patients that needed to be transferred into hospital. The other approach that we took as an ambulance sector was that all the ambulance service medical directors who are members of a national group called NASMED, National Ambulance Service Medical Directors Group, we started to meet regularly in February every week using Zoom video conferencing. And at the early phase, that was an immensely valuable platform to not only understand each other's pressures and challenges, but also to understand where we've been able to develop good practice in terms of how we were managing our clinical coordination centres, how we were managing frontline staff, how we were keeping our frontline colleagues informed, and how we were ramping up our capability to potentially have to manage a tsunami of cases, because one thing that was very, very clear to all of us was that this was a highly infectious disease and that we were likely to see an exponential increase in cases. So that learning from other ambulance services for me was very important, and we also established WhatsApp groups, both formal and informal, and that was another convenient platform for us to share information, to share alerts coming from NHS England, because certainly by March time there was a significant amount of written outputs were being issued to all NHS trusts, including ambulance services, as understanding and as priorities in terms of the NHS's response to the pandemic became increasingly clear. Shortly before, so certainly by mid to late March, the pandemic became very real for me when my daughter returned home from dental school. She's a final year dental student, and she'd been treating patients wearing inadequate levels of personal protective equipment. She was doing what was called aerosol generating procedures using high-speed drilling equipment. And of course, she was living in a university environment and playing sport. But within 24 hours of arriving home after her dental school was closed, Emily was one of the first patients in Oxfordshire to develop COVID. And so we all lived at home with COVID. And for the first time, I had real insights into the challenge of trying to maintain very basic infection prevention and control procedures in your own home with very little in the way of equipment to make that easier. So that provided us with real focus and a real messaging at that time. So Emily's diagnosis was actually confirmed through swabbing just at a time when NHS staff were being screened if they had symptoms for COVID. We were able to get Emily screened. We had a confirmed diagnosis, and we then had to go into self-isolation. But I was able to, as you'd expect, able to continue working from home using video conferencing procedures. And just before lockdown, Keith made it very, very clear to us that really that we should expect to go into full major incident mode, that we should not hold back securing any resources that we needed because of financial constraints. But clearly there was an expectation that we would have to mobilise resources and reconfigure our own staff so that we could achieve a maximum emergency response to the pandemic. And I think that advice helped put us onto a very good footing. One of the things that helped in the early phase of the pandemic, during the first wave when cases were rising exponentially, was that the NHS did switch off all activity other than delivering emergency and urgent care. That meant that inpatient capacity in hospitals was significantly increased. Many of my consultant colleagues were redeployed and became support workers on the intensive care units, so that we were able to increase our capacity. And as an ambulance service, we increased our resources so that had we received dramatically increasing numbers of sick patients needing our support, that we would have been well placed to respond effectively. That preparation was immensely helpful. During the COVID, during the first wave of the pandemic, again in March time, I convened a subgroup of the clinical review group we called it the COVID subgroup, and that was the forum that we used to develop COVID-specific advice for our frontline staff, for our CCCs, and it was a forum whereby all senior clinical members of the clinical directorate within SCAS, when we had representation from the patient transport service, our clinical coordination centres, and we had senior operational managers joining us, and the outputs of that subgroup, where we focused predominantly on clinical practice developments and our understanding of evolution in clinical practice, as well as critically our infection prevention and control procedures. The outputs of that forum were then upward reported to another board subcommittee that we established, which was the COVID operational board, and that board has met weekly, other than for a short period during August, when we went on to a weekly reporting cycle, when we got through the first wave of the pandemic and the 12-week lockdown one. We know that patients over the age of 65 in particular are at much greater risk of clinical deterioration. And those patients now are being issued with symptom diary packs, and we know which symptoms correlate potentially with a more worrying clinical course. So we know that a persistent fever, patients that are breathing quickly, patients who become confused or develop delirium, that those patients are much more likely to need admission to hospital. And we know that patients with a respiratory breathing rate, or if their respiratory rate, their breathing rate is elevated, if their oxygen saturations are reduced. And this type of information, we've now got algorithms that can risk stratify patients into high, medium and low risk, and have been able to advise not only the ambulance clinicians, but also GPs, community care teams, and indeed the initial assessment priorities in the emergency department are also aligned with the type of approach that we're using now in the community when initially assessing and managing patients with COVID. So those outputs are just in the process of being signed off now by NHS England, and we will in the next few days be issuing some further ambulance-specific advice about particularly around the initial assessment and disposition advice for patients with COVID. We'll also be issuing advice to our staff in terms of how patients will be referred into these what will be known as virtual wards, I believe, or COVID at home is the national project. So because it is likely that if patients deteriorate at home and they're not able to make their own way to hospital and enter the hospital via COVID-specific routes, which would usually be the emergency department, but it may not be, then if patients deteriorate, for the patients that can't make their own way, of course the ambulance service will play an important role in conveying those patients to the appropriate part of the NHS. Other initiatives that we've put in place, we've just stood up an adult intensive care inter-hospital transfer service, which SCAS is hosting. We're one of the first ambulance services to be doing this. And essentially what we've done is we've ring-fenced 2 vehicles, 2 sets of paramedics with an ECA. And in phase 1 of this response service, an intensive care consultant will come from a hospital that may need to transfer a patient to another hospital, either within our region or further afield. But I'm anticipating that perhaps later on, as these service matures, that we'll have a dedicated team of intensivists undertaking these transfers for at least 12 hours a day. And that'll be very good news for us, because not only will we be able to offer a better service for patients, because we'll have dedicated vehicles, dedicated resources to undertake these transfers, but Historically, these transfers have fallen to the 999 service, which of course is the same resource that's responding to emergencies in the community. And because these transfers take time, they can be long distance, they may be out of area, that's a significant resource. So I'm very pleased that we've been able to move that forward. So there's a lot of clinical research that SCAS is are participating in. Historically, our focus has been around out-of-hospital cardiac arrest, but moving forwards, we're going to be contributing to a number of research studies, particularly looking at a number of treatment modalities for patients with mild COVID that may be at risk of deterioration in the community. And these will be collaborating with colleagues in primary care, undertaking a number of these studies. So that's an update for me. I hope that's been helpful. Take great care, keep safe, and as I say, I look forward to hopefully meeting you in person in the not too distant future.